Hello, good evening, everyone who have taken time off to watch this presentation tonight. And this actually, the topic is as displayed there, what we can do with PET CT scans is actually a live recording of a live talk given by Dr. Dhamendra, who is a consultant nuclear medicine physician to the Ramsay Sime Dobby group of doctors. But we thought it was too good not to share with anyone else who wants to know more about PET CT scans. So what we'll do is stream the pre-recorded video, but you'll still be able to claim CPD points because we'll show a fresh QR code generated at the end of the talk. But because this is not a live talk, if you post questions, I'll have to forward it to Dr. Dhamendra, and then he can answer them offline for you. All right, so without further ado, I'm going to start the recording. Now, there is about 2-3 minutes section where the audio was quite bad, so I'll try to skip it. Okay, so you bear with us, and I hope you enjoyed the talk. So here goes.
It is my pleasure to introduce to you Dr. Dhamendra Harichandra, nuclear medicine physician who has been with SJMC since 2009. He has a wealth of experience in nuclear medicine and PET CT procedures, both diagnostic and therapeutic. He will be presenting on what can PET CT do. Let's give a warm welcome to Dr. Dhamendra.
Okay, good morning, everybody. I hope you all can hear me. All right, as you know, PET CT has got a very wide usage in modern medicine, and I don't think in an hour we can cover all of it. Basically, today's talk is just to go and get everyone acquainted with, or reacquainted, so much so that what this PET CT is used in our setting, specifically what we can do here in SJMC. Now, as you know, the bulk of the use of PET CTs are in the area of oncology, but more and more so now we are using it for other conditions. And I just want to talk a little bit more longer on oncology, and then I shall touch on the other aspects of usage of PET CT. So before we proceed, just give a brief history of positron emission tomography. That's what PET stands for. This is actually not a new concept. Positron emission tomography was a concept that was brought forward by David E. Kuhl in the 50s. So we're talking about more than 70 years of history behind positron emission tomography. And Dr. Kuhl later on developed SPECT, which is a single photon emission. Single photon emission computerized tomography. This is what we use in our gamma scans. And but he's also known as the father of PET. Now, what's the difference between a single photon emission? Getting this again and again. Can I off this? How is it? Can you hear me now? So, sorry about the interruption. Okay, just go to the next so you don't waste time. So, basically, is that it's a very important part. But we need the bullets in order for it to function properly. And our greatest workforce for PET is throwing 80 or FDG. And this is actually not a new compound. It was actually created in 1976 by Japanese pioneer Tatsuo Ido. My understanding is Tatsuo Ido played the biggest role in developing this particular compound. And shortly after that, in the 80s, it was administered to 2 volunteers by Dr. Abbas Alawi. Basically, is that a PET scanner looks basically like this. It's called a ring type PET system. Before that, basically, they had 2-headed gamma cameras that detect the dual photons to form the PET images. Of course, the image quality is not as sharp as the current. What they did was that they merged the PET scanners together with CT was to get better anatomical localization of the lesions. So this is our old PET CT scanner, which had worked for us for nearly 14 years. We're not given it a funeral yet because it's still functioning. But as of from May this year, there won't be any more, what do you call this, support for it. And as far as I know, the old PET CT that we have is the oldest functioning 64 slides PET CT in the world. Most PET CTs are closed down after 5 to 10 years, but we've been keeping it going on for nearly 14 years. All right. So PET CT is either produced by a cyclotron. This is actually a cyclotron that was the first private cyclotron that was in Sepang. You can see Liao Tangla when he was the health minister officiating it, and in bombard oxygen 18 with protons, and this will cause the oxygen 18 to turn to fluorine 18. Now, lately we've been using also PET pharmaceuticals from generators. Now, what's the difference between the cyclotron? Produce a lot of radiopharmaceuticals, and you must understand that radiopharmaceuticals used in PET have a very short half-life. So we had to go and essentially order a lot in order to do a few patients. And that's very inconvenient, it's very costly. Now, with the S is needed. The problem is that a generator can only produce so much of radiopharmaceuticals at a given time. Because of this, the cost of the isotopes is quite high, because these generators are not cheap. Right? And it's only produced by a few countries, and because of the price is always in the high side. And we try to reduce the price of our scans, mainly because of this. Right. So basically, I just want to tell you what is used in medicine right now. This oxygen 15, carbon 11, nitrogen 13. These are extremely short half-life radiopharmaceuticals. We normally don't use it in clinical medicine unless you have a cyclotron right next door to your PET system, because in a matter of minutes it dissipates. Nitrogen 13s are used mainly for certain types of tumors, particularly concerned with brains, and also we also use it for cardiac scans. The generator-produced PETs are your gallium-68, used for neuroendocrine tumors, rubidium-80 cardiac scans, and copper-62 has got multiple usage. I won't get into it, it's very hardly ever used around the world. So basically, a PET radiopharmaceutical is a PET, which is a radionuclide, which is produced by the cyclotron of the generator, which is combined. And these pharmaceuticals have specific physiological or biochemical properties. A pharmaceutical may target an intracellular biochemical process like FDG, which is a deoxyglucose, an analog of glucose, or it might target a specific cellular receptor, for instance, your gallium-68 PS and gallium-68 dotatate for neuroendocrine tumors. So another thing that PET scan does is that it's actually a scan that has some semi-quantitative properties, and I'm sure that we see the PET scan reports. We look at SUV. Measure the amount of activities in a given tumor and all, and basically the formula for SUV is a tissue tracer concentration divided by injected dose divided by body weight. So the SUV is dependent on the patient size. Remember that the isotope is decaying, so the longer you get, the activities or decreases, and this might influence the value that we get. And also the plasma glucose levels. I will explain to you later on the biochemistry, because into the tumor and just giving us false readings, sometimes even missing a lesion completely. And certain tumor histology would also determine the uptake. Some tumors express the PSMA receptors high, the somatostatin receptors. And it's very important that when we order for a PET scan, we need to know the tumor histology, because it will influence how we interpret the results. Right. Coming back again, the principles of neoplasia that PET is used now, Warburg effect in tumors that, basically their metabolism is rapid, is frequently outstripping the oxygen utilization. And what happened is that the cells would have to, because of increased glycolysis in tumors, there's an increased expression of the glucose transporters, now GLUT1 to GLUT5. I'm not going to explain to you in detail, but basically GLUT1 is the main glucose transporter that's associated with cancers. It's found in many different cancers, which is very cancer. And this upregulation of the hexokinases is a common feature that we use in PET to determine how the tumor expresses itself on the PET scan. So, as you can see from this, but it's just to go and explain to you, there's a lot of molecular biology that goes into the expression of these glucose transporters. And as you can see, this protein kinase AKT or protein kinase B, proliferation of tumor cells, which are important factors that we look in assessing, in diagnosing the disease, as well as to monitor the response with treatment. And this is basically a repeat of what I'm showing us now. Cells, the glucose will enter through the GLUT transporters, and then it's phosphorylized and so on and so forth. But when you use FDG, because it is not it's a glucose analog, so once it is phosphorylized, it cannot be metabolized in the cells. And this is what we see on the PET scans. The FDG that's concentrated in the tumor more than your baseline tissue. So if you have diabetes and your glucose levels are high, it will compete with the GLUT transporters, and therefore the uptake of the FDG will reduce. PET scan, FDG PET scan, sorry. So I'm not going to say anything new. I mean, PET scan has been used quite extensively since the turn of this century. So just to recap what we have known from different types of, from head and neck cancers, you can show that the sensitivity of PET is significantly higher than the other types of modalities. But the problem with PET is that, as most nuclear medicine studies are, and certain conditions like inflammation and all can show a positive uptake. Okay, so in lung cancers, again, compared to a contrast-enhanced CTs, there is an increase in sensitivity. And it also shows that it's better in predicting mediastinal nodal disease, about 15% compared to the conventional scans. And in neoadjuvant therapies, findings because of inflammation, and sometimes you require this biopsies to confirm the presence of disease. And furthermore, in certain types of lung cancers like bronchoalveolar carcinomas, it may not pick up any FDG at all because of the low content of the tumor. So in breast cancers, this is well known already for more than 2 decades that PET scans is superior to conventional studies, about 10% improvement to CT scan bone scintigraphy. May improve the prognosis of inflammatory breast cancer. That means basically we use PET scans to manage these cases, to see the response to treatment, and it shows that it improves the prognosis of patients with inflammatory breast cancer, which basically was one of the worst prognosis in. Now, the problem with PET, again, it depends on how much of the glucose uptake. And we find that in breast cancers, the osteoblastic disease may not pick up a lot of FDG. In this case, the bone scan is preferred. Staging a patient with breast cancer, you should have an FDG PET scan as well as a bone scan, because up to 15% of bone mets may not pick up on an FDG PET, and but it will pick up well on the bone scan. But the cost PET, but whenever we see on the CT component of the scan a sclerotic lesion that's not lighting up on the PET, we always recommend a bone scan to complement it so that you really truly know the true extent of disease. I think a couple of years ago, non-Hodgkin's, Dr. Ng's case, which on the PET scan we keep seeing this sclerotic lesion there, which is not picking up on an FDG. On the breast, there's normal physiological uptake, nothing really intense. And what happened? Sclerotic lesion was getting hotter and hotter, and we're not sure what's going on there. And subsequently, we did a bone scan, and it was lighting up very hot in the bone scan. And a mammogram shows that she had a small breast cancer. This is met. The thing is that with PET scan is that it's not going to replace all the conventional scans that we have right now. It's to complement it. And as any other modality has, there's always some advantages and some disadvantages. We need to be aware of that in order to properly stage and manage the patients. So in this scan that I'm showing here, we can see that on the CT, you can see there are multiple sclerotic foci. On the bone scan, you can see the hot uptake, but on the PET scan, nothing. So this is what I mean, that sometimes we can miss things. And on the CT scan, you can see some osteolytic lesions here, which is missed on the bone scan, but picked up on the PET scan. So each modality basically complements each other. Same thing here, you can see from the PET and MRI scans, the lesion in the MRI absent on the bone scan, but positive on the PET. So again, coming back to sentinel nodes. Now, a couple of years ago, I think when I first joined here in 2010, someone came over and came up with a PET mammogram, and they were trying to better detect cancers and all, but in the end, it didn't actually show much promise. A good thing we didn't get it, because now we now got better tumor mammograms, the digital mammograms and all, they can detect things better. But basically, PET may have a lower sensitivity for picking up sentinel node. However, if you do a PET scan and you find there are lymph nodes which are lighting up, then there's no necessity to go and do a sentinel node to say just do an X-ray clearance. So which is a breast cancer. Next, in recurrent breast cancer, there is a question whether PET scan should be used frequently in screening the patients for recurrence after the initial disease control. The NCCN guidelines doesn't actually advocate that. They still prefer to use normal CT scans and bone scans, and only when there's an equivocal results on those scans, then only order PET scans. Understand that PET scans, one of the reasons is because, same thing as I mentioned to you, it's a very sensitive scan, in which case a lot of false positives may be detected. And when you have a false positive, you tend to sort of increase the cost of the management of patients. So, but in general speaking, in recurrent breast cancers, if you have a clinical suspicion the breast cancer might be recurring, there is an increased PET scan is the ideal modality, and it's osteolytic lesions versus osteoblastic lesions I mentioned before. When you look, there's an FDG uptake on the bone mets. These patients can fare worse compared to those that don't. FDG attack, as I mentioned to you, the tumor is more aggressive, you utilize more glucose. Tumors, I think we've been using quite frequently, but again, there is this caveat. In mucin producing and hepatocellular carcinomas, they have very good degree of glycolytic activity. So a normal FDG PET types of PET scans that is useful for this type, like fluorothymidine or fluorocholine. We don't have that in Malaysia at the moment. We've been trying to get it for the last 10 years, but no one has come up with it. But in the future, hopefully someone will come up that we can actually stage and manage hepatocellular carcinoma just as well as the other two tumors that we deal with in GI, in the gastrointestinal tract. Now, another problem with PET is that a lot of physiological activities in our body use a lot of glucose, and in the bowel specifically, we have a lot of physiological bowel activities which sometimes confounds the scan. And this is why we see sometimes that Durgan and I's report and say, please do a colonoscopy, because occasionally we do find some increased activity, some changes in the walls of the colon that might appear to be a recurrence, and now we actually advocate doing a scope to be certain that disease has not recurred. And in esophageal carcinomas, one of the things that we use is neoadjuvant therapy. Post-neoadjuvant therapy, be it radiotherapy or be it chemotherapy, you'll find that after the treatment, we're not sure whether the disease has responded or not. But with the PET, we can actually see how much a response is. You can see from here that all the tissue plane has been lost after the treatment, but you can clearly see the uptake on the PET. And in local region, the end staging, FDG PET is not that great. You have inflammation, especially patients who have this esophageal carcinoma. They have a lot of reflux esophagitis. You have reactive nodes, and it's difficult to distinguish reactive inflammatory nodes from MET. So PET is not that great for that, but PET is usual cases of distal metastasis, especially esophageal cancer. I've seen one, the tumor actually went to the muscles of the biceps, which you can't really see. A patient doesn't even feel it when the PET was proven to be metastasis. And in gastric carcinoma, now this gastric carcinoma is a bit of a problem because when the patient comes for a PET scan, they are fasting, and almost invariably a lot of them have gastritis. And as I say, inflammation picks up as metastasized, we can usually see it. And this is something that's important because certain types of aggressive gastric carcinoma, like the signal ring type, even though it's an aggressive tumor, it doesn't pick up a lot of FDG. And interestingly, the studies have shown that in signal ring cell adenocarcinoma, if they have lower FDG uptake, indicates poorer chemotherapy effectiveness. So basically, we can actually prognosticate the patient's condition. But basically, if you get other means of monitoring this patient, is preferable. And I think the patient doesn't need to know that the patient has got a very aggressive tumor that's not going to take them. It's not going to make much difference. We're still going to treat the patient. We just have to go and monitor them with using. In colorectal carcinomas, I think this has been established that it's superior in staging and restaging. But again, you've got a lot of physiological activities in the pelvic organs that can sometimes give us a false positive. And but in localizing relapse, when you have a patient who has been treated for colorectal carcinomas and have an increasing CA, PET-CT is good in detecting recurrence. It is insensitive for small lesions. Now, pancreatic carcinoma, sensitivity is good. Most tumors tend to be hypermetabolic, but tumors with mucin production may have variable uptake. And in acute pancreatitis, whatever is it, studies have shown that with using PET, the management of the patient has changed about 30% of the time. And is it not moving, is it? So, glucose control problem is a problem. We have pancreatitis. A lot of patients with pancreatic cancer can sometimes come with diabetes. And if the glucose is not well controlled, we might miss the lesion completely. So it's impact that the patient's glucose is well managed prior to the scan so that we can detect the disease. Now, these are other gastrointestinal tumors. I think one of the most dramatic PET scans that was used for the TKIs, one of the first TKIs that we used for cancers, We can see within 48 hours how on imatinib, the hot gastrointestinal stromal tumors turns off, becomes the light basically switched off, and this shows that it can be variable because of the tumor size and mucin pool, and it's sometimes difficult to discriminate extrahepatic tumors and perihilar node involvement. And in patients with primary sclerotic cholangitis, there's a higher risk of cholangiocarcinomas, almost similarly intense. But of course, if the tumor does occur, it would become more and more FDG avid, and therefore you need serial imaging for these patients to detect disease. I mean, bearing that they're not discovered using. Now, I think with regards to lymphoma, I think it's very well established for staging and evaluation response. There are so many criteria that has gone through over the past 12 to 13 years, from IWC, lymphoma groups, various cervical cancers. Again, you find that any lesions above 5 millimeters, the sensitivity is fairly good and accuracy is good. Now, melanoma, the problem with melanoma is that because the lesion can be quite small, the uptake variable, sometimes we miss small lesions, but it is good for staging. Especially in primary metastasis less than 1 centimeters, you may not pick up that well. But when you do find nodules in the lungs with sarcomas, you need to monitor them with serial imaging. Quantitative imaging systems, we can actually distinguish responders from those who are resistant to treatment, and it allows them to modify the treatment accordingly in the middle of the treatment. And you can't use just the PET alone. How the symptoms is reduced after the initiation of treatment, and looking at how on how the response is in terms of disease-free survival, progression-free survival, and overall survival. Laboratory parameters has to correlate with the PET scan images. Moving here. Okay, I'm going to spend a little bit of time over here. I hope you can bear with me. This is actually a very useful, I think, for those who are treating cancers. Now, basically, cancers are usually not diagnosed until about 10 to 100 gram per se. And this is about 10 to power 10 to 10 to power 11. And ideally, a standard cancer therapy kills by a first order kinetic. Now, in FDG PET, the resolution between is 0.4 to 1 centimeters, and the tumor size is roughly 10 to power 8 to 10 to power 9. So this graph shows after the first few cycles of chemotherapy. Now, as you can see, after the first 2 cycles of chemotherapy, the lower detection limit of the PET is reached, and we can't see, everything is clear. So we say that this particular level is reached a bit later than that, but these 2 treatments, at the end of the 6 cycles, they reach 0. Exactly, I wouldn't call it cure, but basically remission. But often we find that after the first 2 cycles, a response, and we continue the cycles up to the 6 cycles. And on the PET scan, it looks like it's complete response to treatment. But in actual fact, that could be about as many as 10 to the power 7 cells still. And after the interim PET scans, the middle of the cycle of the scans, you find there's partial response, where it is responding to the treatment, but you're not sure whether it's either B or C, whether it reaches right to the cure level or just B. Recurrence is higher because there's a possibility that is beyond the ability of the PET to detect, and looking at the interim scans will help us differentiate those patients are more likely to have a recurrence compared to those who are not. So this in the cases that we have, be it lymphoma, breast cancer, lung cancers. that if the patient has a scan mid-cycle, and if they have good response, they tend to do well. When they come for the yearly scans and so on and so forth, the disease tend to be free. But when the patients have a response, I mean, some have complete response, some have partial response, almost invariably, eventually, it might be a year or so, something will pop up. So this is to guide the clinician, the oncologist, recurrence. And I think the interim scans in PET is very useful in the sense, basically based on this particular tumor kinetics and that we see using PET. Now the problem with PET has always been, as Dr. Allen once said, that nuclear medicine is unclear. The problem with unclear is that it's because it's very sensitive, but not very specific. A lot of things a lot of things tend to PET. That's the problem. You sometimes have to go and trade off specificity for sensitivity. And to illustrate this point, this patient had radiotherapy to the pelvic area. You can see up to the 6 months, there's still hot spot. Now, we can't tell for sure whether tell the patient or just monitor. That's why you need to look at the clinical picture. Is the tumor marker going down? Is the patient doing well? Is he gaining weight, etc.? So we can't use PET alone, and we just need to monitor them down the line. Chemotherapy is also another issue because sometimes it's the chemotherapy is given, and usually we advocate at least waiting for at least a minimum of 2 weeks, ideally after 3 weeks to do. But some patients are going for chemotherapy within that time period. We can't wait for 2 to 3 weeks. So if, for say, the size of the tumor remains the same and the glucose uptake, the SUV goes up, it could still be responding. It's just a flare phenomenon. You just follow them up down the line. And in most cases, the FTG uptake will reduce after a year. So you need to, according to the timing of the treatment. And in radiotherapy, ideally you should wait for 6 to 8 weeks to see how the response. But as I mentioned to you, that even I've seen post-radiotherapy FTG uptake basically need to do serial imaging in these cases. Right, that's oncology. Now there are, of course, a lot more things. This slides that I made, actually I did it during one of the previous talks that I gave in. Then there are more development for each of the different type of cancer, allowing for modifications for the new type of treatments like your checkpoint inhibitors, immunotherapy, and so on and so forth. And this takes individual cancers. So I'm not going to go to it. Maybe in the future I'll discuss about it. But I just want to talk about the other uses of PET. We don't do a lot of these type of studies in SJMC, mainly because our setting is not really real. When you're doing epilepsy brain studies, it's very important that the patient has to be in a very quiet environment so that there's no stimuli that might increase the uptake in different areas of our brain. And it's very difficult to find that, and especially impossible to do that. But hopefully, God willing, once our renovation is completed and things become a bit more quieter, I'm hoping that we can do more of this type of studies. So in PET-CT neurology, it's used in these 3 main areas. Used in those patients with intractable epilepsies, when you want to try to localize the site where you want to do surgery. We can utilize FTG for this purpose. In dementia, right now, the only thing we can offer here in FTG, we're hoping to get some amyloid traces in the future. At the present moment, it's very expensive. The nearest source of amyloid traces is from Singapore. And as you know, the half-life is short. So by the time it reaches here, we need to order dose per patient. So it's going to cost a lot of money to do a amyloid tracer in Malaysia. It's more cheaper for the patient to go to Singapore and do it there. And in brain tumors, again, we only have FDG as our main. ECG is not very specific for brain tumors. It can be used in certain situations. I'll discuss it in a short while. So coming back again, this is just a slide to illustrate. This patient has got tuberous sclerosis, a 1-year-old boy. You can see that there's a and this is actually the cold area is where it corresponds to the prominent right paracerebral frontal lobe tuber. If you're doing surgery and all, this will be a useful guide for you. Now, this is to show the difference between interictal PET and ictal PET. So, in most cases in FDG PET, we can only do interictal PET because by the time we actually come to the patient and give the injection, they're having the seizure would have gone and we can't see it. But we are hoping that once our PET CT center is renovated, that we could have a portable EEG machine in our center, and every now and then we want it, we can inject the isotope and get an ictal PET. Now, ictal PET, the sensitivity is greater, the accuracy of the site is greater. But just to show you the illustration of what it means, this is an interactive PET. You can see the areas where the site of the seizure starts is tends to be hypometabolic. It's basically all utilizes glucose per se and tends to downregulate its glucose transporters, and they tend to be cold. And that's why most of the time you find that in between the seizures, they tend to be sleepy and drowsy. But during the seizures, you can see, and this is how we can localize the areas where the seizure starts. Now, in terms of Alzheimer's disease, now before we had this new type of compounds to look at amyloids in diagnosing and also managing. Now, granted, a lot of clinical data can tell you what is Alzheimer's is, but occasionally you find it very difficult to distinguish one dementia from another. And has been used for the last 20 years, more than 20 years actually, 25 years plus, in helping to distinguish one type of dementia to another. Now, granted that most dementias, you don't actually have a cure for it, you don't have actual real treatment, but at least, it gives some. FDG can be used to see the progression of disease as well. Now, to show this, illustrate this, now, you see all the spots which are purple. These basically indicates the areas of hypometabolism. And each type of dementia has got a certain kind of pattern. Parietal lobes tend to show a reduced uptake. And this is how we tell it's reduced. Usually we have an age-matched database of normal individuals, and we see how much the reduction in uptake of more than 2 in the uptake in that given area, then that area is considered as positive. This map is made based upon that. So this area indicates that in this part of the brain there is more than 2 standard deviation apart from the normal in keeping with Alzheimer's. Now this is in diffuse Lewy body disease. You can see the occipital lobes. The occipital lobes and the parietal lobes temporal parietal lobes are here. In these patients, you find they have hallucinations, visual hallucinations, and one of the reasons because of the area where the disease affects. And this is in frontal temporal lobe. You can see the frontal lobes, the uptake is reduced. Next. Now, we are hoping that one of our vendors may come up with this. This is a flow beta pill. It's a fluorine-18. It's looking for Alzheimer's disease. Now you can see, normal brain. You can see the uptake is intensely strong, the white matter, the brain Alzheimer's. This is actually a more sensitive, specific way of diagnosing Alzheimer's, even early Alzheimer's. And Singapore has it. So far, no. Source here. Right. Now the problem with the brain is that it uses a lot of glucose. And because of this, small lesions may not be visible. In fact, for most of our oncology patients, what we detect on PET scans is not so much the brain metastasis, more like the edema that surrounds it. The edema causes a reduction in uptake. You usually see the cold area in the brain mets more than the high uptake, and it's because the brain activity is so strong. When you have a patient with some brain lesion discovered on a CT scan or MRI, you're not sure is it tumor or infection. And I've heard many other times when the neurosurgeon, the radiologist, they are looking at the brain is a tumor, but when they take it out, it turns out to be an infection, which could have been treated just with antibiotics and so forth. So a PET scan can offer a certain kind of means of distinguishing one from the other. FDG scan, you can see there's an increased uptake in one part of the brain compared to the rest of the brain. And when you do a delayed scan, there's an increase in uptake. So in tumors, because their blood transporters are all upregulated, the uptake increases. Whereas when you have infection, either the uptake is the same or decreases over time because their blood transporters are not overexpressed. It's just a little bit more higher than the baseline. So in this way, we can distinguish between infection and tumor. Looking at now brain tumors now, FDG is really not that good for brain tumors. We miss a lot of things. So just to illustrate that, glioblastoma is really the high-grade ones. They tend to be, of course, aggressive, and therefore they use more glucose. You can see increased uptake there. The same as the rest of the brain, in fact, sometimes slightly lower. And this is why you can miss things on a FDG. But there's also difficulty in distinguishing radiation. Brain, it's difficult to tell whether the disease is there. So we don't use PET, FDG PET for monitoring disease recurrence in brain tumors. Okay, I'm not going to talk much about the use of PET-CT in cardiology. Normal type of PET scans using, gamma scans, these are myocardial perfusion studies, but you know, but PET perfusion studies are actually superior to our old gamma. Expensive. This rubidium-82 generator that we use for getting the isotopes for cardiology is extremely expensive. The half-life is so short, and one generator costs about 200K, and you only can do at most 2K. And the generator doesn't last more than a week. That means every week we need to get another 200,000, and we can do as many 2 cases per day. So it's not very cost effective, and that's why we still use the old myocardial perfusion scan. But just to illustrate something that the heart is using your fatty acids, so the glycolysis is reduced. So, but if there's inflammation in the heart, tends to increase. In this patient with cardiac sarcoidosis, you can see that in the septal area there's a reduction in uptake, but on the FD is due to cardiac sarcoidosis. So in very selected cases, we can actually use the combination of two, but I don't see that anytime soon in SJMC. Hopefully, maybe in the future, but not yet. Right. Another thing that more FDG PET. When I was in UH last time, one of the main usage of gamma scans or white cell blood studies to look for fever unknown origin to find out any localized. But white blood studies is very difficult. Technically, it's very challenging, and there's a lot of false positive and false negative. But with FDG, things are more easier. It's actually more cheaper than using our normal type of scans. So just to show a case of patient with fever unknown origin, you can see the uptake for immunocompromised who has fever and not sure whether the disease is returning or is there an infection. We can use PET to help localize sites of infection. So here we can see two areas in the gluteus as well as in the lung. Now, am I right? So hip prosthesis. You can find that a lot of times after several years after the hip prosthesis is in place, patients complaining of pain. You're not sure whether it's due to infected process. You can see the ESR is a bit elevated. You're not sure whether it's infected or not. If it's infected, we basically need to revise the hip prosthesis. And this is a problem when you have inflammatory activities. You can see here that the area where the hip joint is, there's an uptake there. And this is not infection. This is normal reactive inflammatory activity that follows any kind of surgical intervention in our body. But in the area in the femoral area is more intense compared. And this high intensity is what can tell us there's infection going on. And this is why PET sort of shines, because we have a semi-quantitative means of analyzing the uptake. We can tell how much uptake is here compared to here by looking at the SUV. More than 30%. If it's higher than the rest of it, then we know it's probably an infection is occurring there, because they tend to be intense. Dual time point, we do delay scans also useful because active inflammation tends to be more intense compared to the normal reactive. This is now being used more and more around the world to detect prosthesis infection. Now, just as we use FDG PET to look at response to treatment, we can also use response for very chronic heart infection like fungal infections. You can read the story from the slides here. Essentially, this patient got a fungal infection, which is showing uptake on the PET. It was given the first course of antifungal, which shows it almost disappeared. You can see the changes there on the CT. And they changed the antifungal treatment, and then they monitor down the line, it's cleared. And although there's a nodule over here, there's no uptake here. So we can usually use FDG PET to monitor response to certain kind of fungal infection. And I've been told that the latest article that came out about 2 years ago showed that even in tuberculosis, we can actually monitor the response, especially those with multi-drug resistant TBs. We use PET to see any additional drugs need to be given. Now, again, this is a case of Spondylodiscitis, patient who had infection to the lumbar vertebra. You can see the activity is hot. Again, we used to give about 6 weeks or even a couple of months, but sometimes the infection can still reside. So we can use PET to decide how long should we continue. That means we give a course of antibiotics, be it intravenous or even oral antibiotics, and then we do a scan afterwards. If the uptake is not, then we can stop. So you can actually use this to go and help manage patients with infection, FDG PET. Right, and actually had wanted to go and present a couple of new papers. Things which are established right now. FDG PET has been used for quite a number of years to diagnose arthritis. If a patient is you suspect to have arthritis, you can see from here the increased activity in the root of the aorta, the celiac trunk. And this is a patient with spondyloarthropathy. You can see there's increased uptake in the sternoclavicular joint, the sacroiliac joints, as well as the hip joints. So in patients like this, that you're not very sure whether the patient is seeing some disorder, FDG PET can be utilized for the diagnosis. Primary sarcoidosis, I think we have used quite a bit. You can see the uptake in the mediastinal nodes, the changes in the lungs that is typical of sarcoidosis. As well. So what PET scans can do? Now, they are most useful when it's used to ask a specific question. Quite a number of times when you order for a scan, they are doing something general. Patient loss of weight, serious. You catch something, but sometimes you may not. In PET scans, because we are looking at functional things, we need to ask a very specific. Let's say the patient is having some pain over the lumbar area, but it's also having loss of weight, loss of appetite. Just now, you might have an infection in the spine, or you could have a malignancy inside the spine. So you need to have very specific questions in order for FDG PET. If you do something which is general, we tend to have garbage in, garbage out. You will tell, oh, there's a hot spot there, it could be this. Hot other. Is low, they tend to do poorly with chemotherapy. So it can use for prognostication because it has a quantitative aspect to it. And just to reiterate the point that nuclear medicine scans, including PET-CT scan, is a clinical correlation with the significance of the findings, which means that we can progression, is it malignancy, is it inflammation, so on and so forth. The history is important. I know I don't expect the doctors to write the entire clinical history of the patient in our request form, and that's why sometimes I have to ask for your forgiveness that we give all kind of potential possibilities. The patient has got past history of malignancy, this could be this. The patient has got constipations and all. The spot that we see in the bowel may not be physiological, could be a colonic neoplasm. So the differential is a lot. So you need to call it. Should end my one. So open the questions.
Do you have any questions?
When you do a follow-up scan, say, monitor infection, when you monitor. Okay, I think I'll stop here in the interest of time, and I want to do apologize for the audio quality, but that was, I think, related to the streaming during the Teams meeting. So there was stuttering and so on. I hope we can do better next round. But I thought it was a great talk by Dr. Dhamendra to give us an overview of what PET scans. So some of you may just think that PET scans are only in oncology, but he's shown that it can be used in neurology, in Alzheimer's, infection, and other inflammatory disorders as well. So I hope that you found this talk informative. I mean, PET scans have come a long way, and I remember decades ago when they first started, our patients did not have access to PET scans. They had to go all the way. There was not even available in Singapore, but they'd go all the way to Hong Kong, and where it cost an arm and a leg, And I think if I remember, it cost around 10K back in those days. Then when it came to Singapore, patients had to go down to Singapore. But thankfully now we have quite a number of PET scan centers in Malaysia, and I'm fortunate to work in a center with good PET scan. It's not just a scan, but actually the quality of the reports and the new, which are important. Okay, I've been asked to show. Before I give you the QR code for the CPT point, I've been asked to show this. Hang on a second. This flyer, I think, have I got the right one? Yeah. This is the Dr. Dhamendra in his talk mentioned that the PET scan in SJMC was quite old, but actually we've now got a brand new generation PET CT scan, okay, with which is faster and delivers exceptional quality. And it's interesting that even when things get better, they get cheaper. So currently, scans have dropped by more than 1,000. So they are now only about 2,003 per scan, and these are really high quality scans indeed. So now I'm not a nuclear medicine physician, so I can't really take questions. If you have any questions, please feel free to post them in the forum or in the YouTube video as a comment, and I'll forward it to Dr. Dhamendra, and we'll reply accordingly. Okay, now I would like to now share with you the QR code, and here we go. Nope. Hang on. This is a reminder, you need to have your 30 points by tomorrow. Tomorrow is the last day for you to accumulate 30 points. So if you've not accumulated by then, you won't be able to apply for your APC next year. All right. Okay. Sorry for the interruption, and let me try to get the image of the QR code. Okay. Can you see that? Okay. This code will be valid for about an hour, so I'll leave it on, and if you can use your MMA app to scan, you should be able to get a point. Thank you for watching, and if you appreciate, let us know by liking the video and subscribing to our channel, and feel free to make a comment. If you have any feedback, or if you'd like to see more of any particular medical topic you'd like to see more of, please comment on the video, and I'll pass the feedback on. I think I'm fortunate to have colleagues who are willing to share their knowledge, and it's a waste if our SJMC talks are not shared with the rest of you. I feel that there's a lot to learn. Medicine is a lifelong journey, right? Okay. All right, so I will leave this running, and I will bid you all good night, and have a wonderful rest of the week. Okay, take care.
you.